I'd just like to thank everyone involved in this meeting. This meeting was very instrumental to my development as a surgeon. I was here in 2018 in Houston, and after that I started doing anterior hips, and I can't thank everyone who dedicates their time to this course. It's been very valuable. Also like to thank Synthes for giving me this opportunity, and DePuy. These are all opinions expressed by myself. So what I'm here to talk about is DePuy Synthes has enabling technologies which I've used in my practice to make the anterior hip surgery reproducible and easier. So I'm going to talk about the active stem and why I switched to that. I'm going to talk about the concise impactor and also VELOS hip navigation, which was a game changer for me. So a little background about myself. I'll talk to you about how I was an anterior surgeon, went to posterior, then back to anterior. I'm going to talk to you about how when I went back to anterior hip replacement, I used enabling technologies to make the transition easier, and also encourage you to talk to your patients about using enabling technologies and give you a case example. So this is where I live. This is where I practice. I live in a really rural town, small critical access hospital. I was the only orthopedic surgeon for 6 years until a month ago my new partner started, which I'm excited about. So for me, I think the stakes are high. These patients that I'm seeing are people I see in the community, I see them in the grocery store, and they're my patients. So this is all the hips I've done since I've came here. I started at the end of 2014 when I finished my training. I was doing anterior hips. You can see I slowly transitioned away. I was doing purely posterior hips in 2016, 2017. I decided to re-up, and I had to go back to anterior hips because I actually truly felt it was a better surgery for my patients, less complications. So I went to this meeting in 2018, and then as you can see from 2017 to 2019, I doubled my hip practice. And on top of that, I went from purely posterior to a purely anterior hip approach. So what was I doing wrong the first time? I went back and analyzed everything I was doing wrong. I was using an ML taper style stem, which, I was having some issues with subsidence. I was having a poor broach stem envelope. I wasn't using any technology, so I was using my eyeball. I was trying to use a primitive way of judging leg length and offset. I was using a generic hip table that I couldn't elevate the femur. And I had a different team every day, which I just don't think is a good idea. So in essence, when you're doing an anterior hip replacement, you got to conduct an orchestra. You want to decrease the headache you have. So this is my old stem. This is a posterior hip I did previously. You can see my cups anteverted more than you typically would from an anterior approach. It's slightly bigger than you typically would use. And this is what I call the halo maker. Every one of these stems I put in, they had a halo around them, and I followed them. And some people had thigh pain. I didn't really see the clinical significance of this other than I was always worried about the stem being loose. This is the new active stem, which I've been using exclusively now for 2 years. I used it in everyone. The advantage of this is it has a collar, which I really believe in the collar. I like to know that my stem's not going to go anywhere. It's not going to subside. It's got proximal dual fixed coating. It's got a reduced lateral shoulder. This thing was made to be put in from the front. It's fully HA coated and has a triple taper. This is the concise impactor. So I'm going to play a short video. Basically, this video shows me broaching a large male femur in less than 2 minutes. I'm only going to show a short clip of this. The important thing, I want you to see when I'm doing this is basically I'm broaching the femur with my thumb. So I'm not using my shoulders. I'm not using a mallet. I'm simply pulling the trigger with my thumb, and I'm broaching the femur. And I use this for everyone. I use it for little old ladies. I use it for osteoporotic fractures. I think it's the most reproducible and consistent thing I use, and I just love it. Last thing, we'll talk about hip navigation with VELOS. So basically, what is hip VELOS navigation? This is actually something I saw when I came to the meeting in 2018, and this was what led me down to switch my implant in my company. So basically what VELOS hip navigation is, it tells you your exact cup position at the time of surgery, and you can argue what the appropriate anteversion inclination is for a patient, but at least this tells you exactly where you are. So this shows this patient's at 43 degrees of inclination, 22 degrees of anteversion, and most importantly on the side here, it tells you your leg length and offset options with the modularity of the implant. So if I want to increase the patient's head size, it tells me exactly what that equates to in millimeters and offset for that patient. So when I went back to anterior hips, I kept asking myself, how do I decrease my complications? If you look at leg length, VELOS. VELOS tells you your leg length, you know what it is before you leave the operating room. Dislocation, well, why do patients dislocate from an anterior approach? Typically it's cup malposition and leg length and offset that's not been reproduced. So the solution for that is VELOS. Subsidence, issues with that, well, simple, use Actis. It has a collar, use concise, so you can cram the biggest stem you can in. intraoperative fractures. Ironically, when I first saw Concise, I thought that I was going to have a problem if I used it for that reason. But actually, I trust the Concise more than I do myself with a mallet. I've never had a calcar fracture using Concise. And like I said, I use it on all my patients. And lastly, how to decrease the operative time. Just use all of them together with the HANA table, and everything is much easier for me when I went back to anterior hips. So in summary, the surgery is hard enough. And when you're going through the learning curve and you're going back to doing anterior hips or starting off in practice as a young surgeon, you have a lot of variables, a lot of things you're worrying about. Just use the best tools that are available in your hands. Here's a case example. Again, small town. This is a patient I see all the time. And, you know, for me, this is high stakes. These are like every patient I see, I know personally, and I want them to have an excellent outcome. So you can see her hip x-ray here. Her hip is arthritic. Her hip is short, and she's also getting pathologic offset. Her hip is going up and out. In my experience using this for overlays, this is a really challenging hip to use overlays and get perfect. So here's my intraoperative data. So if you look at the image on the left, this is my preoperative fluoro shot, and I blanked out all the VELYS hip navigation, all the software and all the information it's giving me. And I just want to make a point. If you look at my x-ray on the left compared to the x-ray on the right, I would challenge anyone to look at that and know specifically and exactly how much I'm lengthening this patient and how much offset I'm adding. So this patient, I medialized her cut more than I templated, and my neck cut's a little higher than I templated. So I had a plan going into it, but I deviated. But with VELYS hip navigation, it tells me exactly how much I did. I gave her 5 millimeters of length. I gave her plus 8 millimeters of femoral offset, and I decreased her pathologic offset by 4 millimeters. So this is my postoperative x-rays. Her leg length's restored, offset's restored, and most importantly, the patient's happy. So it gives you data to help make implant-based decisions, and it's simplified. It decreases your fluoro time. It's CRM technician agnostic. Any CRM tech can do this and be successful. The software tells you if there's an error, so it accounts for magnification, accounts for abduction, adduction of the leg. It also tells you if the pelvis moved. That was one of my biggest problems when I started doing anterior hips again. The pelvis would shift when I take the head out or I dislocate the hip. And then all my C-arm shots that I had before were not helpful anymore. And I'd already made my neck cut. It also integrates your sales team consultant, allows you to template and communicate your plan prior to surgery. It also allows them to do the data registration during surgery so you can focus on doing the surgery. And I challenge you to do one case, use whatever old technique you use to measure leg length and offset. And after one case, doing a trial with this, you won't be using overlays anymore. So patients, they want to know exactly what you're doing when you're doing hip replacements. They want consistent and expected outcomes, minimize pain, minimize complications. And patients have legitimate fear of leg length inequality and dislocations. Patients know someone who's dislocated and they just don't ever want that to happen to them. So I'm always actively talking to patients about that. You know, why did you come to see me? How do your legs feel? Do they feel even? Do you know the technology I use during surgery? Have you seen my website? And have you seen my YouTube videos? I challenge you all to do some kind of videos for your patients so they kind of know the technology you're using. These videos are easy to make. They're short. You put them on YouTube. I have a lot of patients coming to see me and they're like, are you using that technology for my hip? And so they want to know that they're going to get what you're planning to do, and they want to make sure they're going to get their leg length right. This is just a graph. These are all the anterior hips I did. So the ICGR course was September 2018. And then you can see I released a video in March. 2 months later, I had an uptick in patients come and see me. And then same thing in July, released another video. So patients definitely see this. Patients are definitely interested. They're all interested in the anterior approach. I think people out there are aware of it. These videos just help them. This is the old way. I can't believe this is how I used to do surgery. I used a cob to measure leg length. So in summary, DePuy Synthes has enabling technologies to make your life easier, to simplify the direct anterior approach, to improve your outcomes with these tools. I would encourage you to use some kind of enabling technology and also to talk to your patients about that. And then this is a shameless plug of a video I made. This is basically a surgical technique, if you will, of doing VELYS hip navigation with the anterior hip approach, with the Concise and the active stem. So if you're interested in watching this, it's a 4-minute video and shows you a step-by-step on what to do. So thank you very much.
Dr. Lindsey, we have just a few questions for you.
Sure.
Do you always implant the pre-op templated size?
No, it depends. So the hard part for me is getting the magnification right. So I used to use a ball marker and I kept finding that I was inaccurate with where the techs were putting the ball marker on the x-rays. So generally I go into it with a plan of measuring a female's head as about 47 and a male's head at 51. So I'll adjust my intraoperative templating in my plan based upon what that shows. So if I measured the patient's head at being a 55, I know my stem's going to be different. But the thing I like about Concise, when I use it, when the broach stops, I know that's the biggest size I can put in. It just physically stops.
Okay, great. And next question, has your post-op routine changed through use of technology?
Yeah, so I mean, I think most anterior hip surgeons don't restrict their patients post-op, but I basically, when I get done, I tell patients they can do whatever they want. I don't restrict their movements afterwards. I also have confidence that it's not going to subside. So with the collar and everything, so I basically just tell patients to just don't do anything that hurts. And you know, that's my only kind of instructions after surgery.
Okay, next, how long did it take you to get comfortable assessing rotational stability of the broach while using the Concise? Many surgeons are used to handling the broach handle to assess that.
Yeah, I mean, you can do the same thing with the broach with the Concise. You can rotate the femur using the Concise handle, but you'll find that when you use the Concise and the way the active stem is, you'll know when it stops, and you can check rotational stability. It's very rare once I trial to go back in and actually change the stem size. It's almost always the final broach is the final stem.
Okay, and last question, do you ever use a mallet or do you use an automated impactor for all cases?
I use an automated impactor for all cases. The only time I use a mallet is if the battery went dead because I used it too much, which is very rare. But no, I don't use a mallet anymore.
Okay, and sorry, one more question. What was your learning curve number before you were comfortable?
So when I went back to doing anterior hips, I did all this at once. So they sometimes say you shouldn't switch approach, switch implants, and use a bunch of tools you haven't used before. But I felt that these tools all solve the problems that I was having prior. So I used them all at once the first time, and then haven't changed since.